everyone. Just to let you know, as it says in the chat from Lee, that this session is being recorded so that people can enjoy it over the coming days and weeks on the Trust Network, but welcome those who are here live as well as those who are seeing it recorded. My name's Ashley Shaw and I'm the Medical Director at CUH and co-chair of the Purple Network, co-executive sponsor, of the Purple Network. Sorry, I'm changing my job already. And I'm pleased to introduce today Gail Leeson and Nicola Clark. Next week, the 6th to the 12th of May, is Deaf Awareness Week, and the Purple Network are hosting with two of our staff from the Emmeline Centre. The Emmeline Centre, as you may know, is a multidisciplinary team that works with individuals with hearing losses that require specialised hearing devices to support their listening needs. The rehabilitation team work closely with the team's audiologists to assess candidates for hearing devices that support both sensory neural and conductive hearing losses. In addition, the team provides lifespan support for individuals on their listening journey. Their work involves supporting not just the patient, but also liaising and working with all professionals working with the individual and patient families. So if I come on to the two individuals themselves, Gail Leeson is the lead rehabilitationist. Gail's worked in deaf education for the last 20 years, for 20 years, then joined the Emmeline Centre in 2018. Before that, she was the educational audiologist and lead peripatetic teacher of the deaf within the Bedfordshire sensory team, and worked as a qualified teacher of the deaf with a specialised school for the deaf. Nicola Clark is the senior adult rehabilitationist within the team. Before joining the Emmeline Centre in 2016, she was employed as a speech and language therapist on acute hospital wards, working mainly with adults with neurological conditions on swallow and communication impairments. So that's our esteemed speakers. I'm now going to hand you over to Gail and Nicola so you can hear their talk.
Thank you, everybody. It's really lovely to be able to chat to you today and for people to catch up when it's recorded. It's really nice to have this opportunity, just as a pre-warmer to next week with Deaf Awareness Week, to just think about how we can support both colleagues and patients within the hospital who may be having hearing difficulties. Just to start with the first slide, if that's okay. I think before sort of kicking off, I just wanted to give you some numbers as to sort of the level of difficulties sort of within the UK. So listed on the BAA, which is the British Academy of Audiology, there's approximately 11 million people in the UK who have a hearing loss. It's therefore the second most common disability in the UK, affecting about 1 in 6 people. 8 million people are aged 60 or over. And this sounds quite precise, but of the 6.7 million who could benefit from a hearing aid, only 2 million people use it. So therefore, what it makes is quite a challenge in many ways, because it's not always easy to tell when somebody might benefit from support. It's not like an individual who might have a broken leg and you can visibly see that that person needs support. You know how to help them. You can get the resources quite quickly. But with a hearing loss, it's much more hidden. And therefore, one of our key messages from today is really you mustn't assume that everything is okay, because it might not be. But with simple adaptations, we can make a significant difference for individuals, and we can really help them engage and sort of fully in conversations and social situations. So that's the plan of today, is just to have a little brief overview of how we can do that. Could you have the next slide, please? So just a brief overview, we would just quite like, Nikki's going to talk through some communication and support strategies, just to sort of make us aware of those. We'll have a very brief overview of what we do within the hospital in terms of our roles and departments that support hearing loss. We'd then like to just to introduce, how can we support inpatients within the hospital, and then hopefully there'll be time for questions and our details if you wish to contact us at a later date. Thank you.
Okay, hi everyone. Yeah, I'm just going to talk through some really general communication strategies to support people with hearing loss. So this encompasses really both staff, family, friends, patients. You know, it's just some really general advice. Because as Gail said, hearing loss is a very hidden disability. Many people are quite embarrassed to disclose it, and sometimes our patients report that people are quite embarrassed to talk to someone with a hearing loss because they just don't know what to do. And communication is very much a sort of 50-50 responsibility. There's the responsibility of the person with hearing loss, and it's the responsibility of the person speaking to them to make that communication effective. There are many other strategies, but these are just sort of some general ones. And the first thing really is just do not be afraid to ask the person what they need, what helps them the best with their communication with you personally. It can feel quite confronting and, as I said, a bit embarrassing, but just get it out there, have the conversation, don't be afraid to ask. Okay, the next one is lip reading support. Everybody with a hearing loss lip reads to some extent, and I don't mean formal, having gone to classes lip reading. Even normally hearing people will lip read in a noisy environment with background noise. Our brains just make use of the visual parts of our processing to support the auditory. It's a very natural process. The general advice is just clear lip pattern, but don't over exaggerate, because that can really distort the lip reading for the person with the hearing loss. And don't cover your mouth is a big one. Obviously during COVID we had huge issues with our patient caseload with mask wearing. It put such a barrier to communication in every situation, and particularly in a healthcare setting. It really did remove most people's communication support. There are clear masks available in the trust. I'll talk about this a bit more later, but yeah, we do need to be thinking about mask wearing when people disclose a hearing loss to us. So the next thing to think about is background noise. This is significantly problematic for people with a hearing loss, as it is for people with normal hearing levels too. Just try and reduce it as much as you possibly can. Think about whether there's a TV on, a radio on. Even an open window can really distort an auditory signal for someone with hearing loss. There's lots of bits of techie equipment that can help with background noise. There's things like personal microphones, ways to direct microphones with various hearing equipment. And for any staff listening with a hearing loss, just to see if you're aware of the access to work funding that's available. So there is a pot of money available for anyone that needs any extra equipment to support them accessing work or staying in employment. And we're happy to be contacted if anyone wants to discuss that further and give you some details on it. The next thing is group conversations. Again, really problematic with hearing loss. They're much harder. You've got lots of multiple sources of sound coming in instead of just one clear speech signal coming in at one time. Your brain is working so much harder to decode lots of different sound signals to an already limited signal. So your brain's already doing a jigsaw puzzle to try and put together the fragments of speech it's hearing. Add in lots of different channels and it does become very problematic. So for staff, if you're in an office environment, just be aware that that's going to be a really difficult situation. And yeah, just if you are in meetings or group conversations with someone with a hearing loss, just try and be mindful of talking over each other and everyone talking at once. It does become really difficult. The next thing, positioning, is worth mentioning. As I've said, most people with a hearing loss, or all people with a hearing loss, will lip read to some degree. So make sure you've got enough lighting on your face. Stand close by to the person you're speaking to. Make sure you're not standing in a shadow. And also facial hair is really problematic for people that lip read. So yeah, just sorry Lee, I'm not looking at you. But just be aware that it can cause extra problems. So you might want to just have an open conversation with a person with hearing loss to say, if you're struggling to lip read me, what else can I do? How can I support you? The next thing is checking that people have understood you. It's masking is a very common behaviour that comes from years and years of not hearing people, getting embarrassed to ask them to repeat, and then still not being able to hear. So people do tend to sort of retreat into themselves, nod and smile and pretend that they've understood, because that's easier and less embarrassing. And it does cause some fairly significant mental health problems by the time people get to us in a severe to profound clinic. This has been years and years of retreating and masking behaviours. So what can you do to check someone has heard you correctly and to support them with that? Just ask them, obviously, if they've heard you. Rephrase it if they want you to repeat. Try and rephrase it in a different way. Sometimes different words you use will have a clearer lip pattern to enable them to hear you properly. Use signing, gesture. I mean, obviously not all of us use BCL, but just a simple hand gesture can really help. Write things down, especially on the wards, when we're talking about background noise and lighting and all those things that become especially problematic on inpatient wards. So yeah, writing things down and just ask questions to just check that they're following you okay, especially for important information. The last thing I just wanted to mention was using the phone. The phone is one of the first things that people find difficult when they are experiencing a hearing loss. It's usually one of the first signs, and something that people are unable to do quite quickly because you don't have any of that visual input to support your brain's auditory input. So yeah, for staff listening, the phone can be really, really challenging, and it can be very embarrassing to admit that you can no longer do your job if it involves phone work. So again, the access to work funding is there for equipment that, again, please contact us if you want any help with that. But if you're talking on the phone to someone with a hearing loss, just be clear, use separate words, slow down your rate of speech, but again, remain natural. Try not to waffle and use all the fillers. Just be really clear and concise. Avoid changing the topic too much, things like that. And just give the person a little bit of extra time to process what you're saying. Don't be afraid of leaving silences, because their brain is working extra hard to process this information, and it does take a fraction longer than someone with normal hearing. Okay, I think it's back to you, Gail.
Lovely. So you've heard a little bit about within the hospital, the Emmeline Centre, but I just thought I would put this slide in just so that you're aware of a little bit of what we do and perhaps the regions that we cover. So obviously within CUH we've got sort of two departments. There's the audiology clinic in Clinic 10, who deal with paediatrics and adults within the Cambridge area, and also supporting individuals not just with hearing loss but potentially balance issues or other hearing complications such as tinnitus, which is also quite prevalent amongst people. As Nikki referred to, the Emmeline Centre is more for the severe to profound in terms of cochlear implants, but my following slides will show you the range of devices that we also deal with and offer, which is a bit broader than that. But we cover a wide area in terms of region, and really get very much involved in all the different areas. We are a multidisciplinary team, so we have surgeons, audiologists, teachers of the deaf, speech and language therapists, nurses, and we have an active research department as well, led by Professor Banks, who's also involved in our HIDO clinic, which is for, and I always forget the name, Hearing Implant Diagnostic and Optimization Clinic, which is for individuals who are experiencing sort of extra difficulties, and so there's a lot of input and time spent to try and help individuals with more complex situations. Next slide, please. So I don't wish to go into chapter and verse about hearing loss, but I just thought very briefly just to highlight, when we're thinking about the type of devices and the kind of support we perhaps need to offer people, there's two main things we're looking at. A, the severity of their hearing loss, and we are involved in assessing and getting audiograms from individuals as to how loud sound has to be in order for them to detect it. And as the diagram shows, the further down the diagram you go, the more profound the loss is described as. We also think about the nature of that loss. What is causing that difficulty in hearing? It might be a conductive loss, in which case you might have an issue with the external pinna or the ear canal, or you might have an issue in the middle ear. You might have glue ear. You might have the ossicles not working correctly, and we describe that as a conductive loss. Or you might have something involved in the inner ear, which is described as a sensory neural loss, where the hair cells might not be moving correctly and not activating the auditory nerve sufficiently to send messages for us to understand. You almost might have a mixed loss as well, so you can have a mixture of the two. But we take these two aspects into consideration, and when we're assessing individuals, also looking at how well are they performing currently before looking at other devices that they might need. Next slide, please. So, as I say, with severe to profound losses, cochlear implants is possibly the main device that we deal with. You need two parts to a cochlear implant. You have the internal part, which is implanted into the cochlea, so it's replacing the part of your ear that isn't working quite so well. But you also have an external part, which looks more like a hearing aid, but has an additional coil as well. And really, you obviously need that processor on in order to access sound. If that coil is off, there is no sound being sent across through the skin to activate the electrical stimulation that you need in order to activate the nerve. As Nikki referred to before, cochlear implants are not magic. They are not a magic wand that make everything okay. They should be viewed as just very powerful hearing aids. So in noise is still an issue. It doesn't necessarily reduce that problem. So whether you've got hearing aids or a cochlear implant, that's still a problem for individuals. But as the last picture shows, there are additional devices that you can make use of that give you a better sort of input of sound, and the individuals often can make use of those, and we'd recommend using those too. Next slide, please. So another device we use is bone conduction hearing devices. They can be worn in different ways. So children tend to have them on soft bands, whereas adults may have them on a fixed abutment. They deal with a different type of hearing loss. So it's more to do with a conductive loss. And as I say, you might have glue ear, you might have the bones not moving properly, or you might have microtia in terms of the external part of your ear not being formed correctly, or atresia in terms of the canal not being formed or very narrow or blocked. So all of that is stopping amplification of sound, so meaning that you're getting a reduced input of sound. And it's delivered through the device vibrating, and through that vibration it's sent through the mastoid bone to the inner ear. So for this group of individuals with this type of loss, which is demonstrated in the little chart, that would be something we could offer to support them. Next slide, please. But not everybody likes a soft band, particularly paediatrics often get to the age of 7 or 8 and they go, do you know what, I'm really not keen to wear a soft band anymore. So for those individuals or adults as well, there is a middle implant that we can offer, which if you look at the middle picture, the bone bridge, there's two types of middle implants. Bone bridge or ossea are the two that we offer currently. The part at the end vibrates in the same way as a Baha does, but it's just fully implanted. So that's all underneath the skin, and then you have the external processor part which picks up the sounds and sends it across the skin. The other one we do is called a vibrant sound bridge, and as the diagram below shows, that's implanted not dissimilar to a cochlear, but it's got a transducer at the end that attaches to the ossicles, which then moves that part to enable to amplify sound. So they work in slightly different ways. And for this group of individuals, you could have a mixed loss or a conductive loss. And there are, again, additional things that somebody could wear to help enable you to hear sound better in noise. So they all do slightly different things, but they're the range that we offer at the moment. Next slide, please. So what do we do with individuals when we catch up with them? We're involved in the assessment, so we need to assess and make sure that we fully understand how they listen, how they're perceiving sound, and what their communication skills are like. We need to check their suitability for the type of device, and an important part in the rehabilitation side of it is checking their motivation and assessing what their quality of life is really like, because as you can imagine, these are invasive surgery, and we want to make sure that people are really on board and fully understanding of expectations and what their outcomes could be. So that is a big part of what we do in assessment, to make sure that they're on board with what they need to do. We also play a big part, particularly in terms of the paediatrics, in terms of liaising with the local communities. So we work closely with local teachers of the deaf, schools, parents, other professionals who might be involved, so that we have a full picture of patients when we're dealing with them. Also, in terms of post-surgery, we're making sure that, having got the devices that we feel they need, how are they doing? What is their outcomes? Are they performing as well as we would want them to? If not, why not? And that's where our HIDO clinic comes in, a really useful place to help us assess things. And we make a big point of monitoring a long term how they are doing, and making sure we support appropriately. Nicola, is there anything you wanted to add to that?
No,
No,
good.
okay,
Thank
cool.
you.
Next slide, please. Over to you, Nikki.
That's me. I just wanted to turn our attention lastly to how we support our inpatient cohort with hearing loss. So there was a recent CQC finding that identified very poor patient experience from those who are hard of hearing, and it's something that has been picked up in the trust, and we are looking at. But just some general notes on how we support our inpatients for those of you that are ward-based. Just really obvious things, but they make such a difference. But just ask the patient if their hearing device is working. A hearing aid on a patient's ear with flat batteries is obviously not going to do anything. So please ask them. Most reception areas in the trust have a loop system, and most hearing aids and cochlear implants have a loop program, so patients it supports their hearing in that situation. If you do have one and it's a little bit ancient, it might be worth just checking that it's working. They are supplied by estates, but we can help support checking that it's working, because we can bring a hearing aid up to you and do a listening check with it. I've talked about communication strategies, but it's key, especially on noisy wards. And I've mentioned that clear masks are available for use. So if you do have someone with a significant hearing loss, please do get a stack for your ward. Ask the patient's family, or if the patient isn't able to tell you themselves, about their communication style, their abilities, because worst case scenario is that we don't, from my experience on the wards, when communication with a patient is limited, it's harder to get a picture of where they're at and what's changed. So yeah, chatting to patients' families can be really valuable, and just make every attempt that you can to support that patient's involvement in their care and with their treatment. It's a very it's very isolating and scary place to be in hospital and to not know what's going on and not be able to communicate to the normal standards. And assumptions can be made, which I think is something that came out of that CQC report. Okay, next slide, please. So there is a poster available that we've done that is available for anyone who is having an inpatient stay with a hearing loss, just to make people aware that they have a hearing loss and that they need to check that their equipment is on to communicate with that patient and that it's working. Excuse me. And there's some general strategies on there as well. We've put our contact details on there for changing of batteries or anything. We are really happy, and we have done on quite a number of occasions, if someone is admitted with any of our devices, and I speak for us in the Cochlear Implant and Hearing Implant Centre and Audiology for hearing aids, we will come up and we will provide batteries. We will check that things are working, and we will support that patient to get their equipment working. Not knowing how hearing aids work or cochlear implants work shouldn't be a barrier to that person being able to hear and participate in their care and conversations around their care. So yeah, the poster can just be a bedside one, very similar to the yellow ones that speech and language therapists put up behind the beds in terms of communication support or swallowing guidelines. So yeah, it can just pop up behind the bed, and we've had approval for that use in the trust. One of the main points to make, another shocking or hearing aids that are lost during inpatient stays. They get swept up in the linen and they just go missing, which is no one's fault, but just to be aware of the cost of the equipment. This is all NHS funded equipment. A hearing aid on average is about £165 of NHS money. A cochlear implant is between £7,000 to £8,000 for one processor. So if that's being swept up with linen, that has serious implications. So this is part of our drive to kind of make staff aware of the high cost of this equipment, the high value of it, and to please support the patient to take care of it and protect it from loss or damage. Yeah, so I think if we go through to the last slide, I think we're 5 minutes over, sorry, but that's kind of everything from us. I hope it covers everything that you were expecting or wanting. We're really happy to be contacted. There's a link to our website there. We're on the CUH page. We have an Emmeline Centre page with lots and lots of information about hearing loss, about our referral process and how to support us. Audiology have the same. Our email addresses are there. We're really happy to be contacted with any queries. So yeah, thank you very much for listening and for your time. I think there is one question in the chat, isn't there? Gail, that might be one for you. Can hearing aids assist with chronic eustachian tube dysfunction? I manually pop my ears as this was the only advice given when diagnosed, but still struggle in louder environments.
Yeah, so that's kind of linked to glue ear and fluid in your middle ear. So yes, it can do. I guess it's one of those situations where if you get a lot of blockages, you don't necessarily want to block them up, but if it helps, particularly in terms of noisy situations, yes, then that can be useful. But yeah, that is a problem for if your middle ear gets a little bit blocked up. So yes, I would say yes, investigate.
Okay, thank you.
Any other questions from anyone? I know there's not many people on at the moment, but
I have my hand up.
Hello,
Nicole, thank you so much. I'm walking away with so much knowledge. Thank you so much for the presentation. My question is supporting someone, maybe elderly patients, who maybe cannot communicate that their hearing aid is not working. Is there a way staff can check if the battery is full or if it's working? Does it make a sound? Is there, because I wouldn't know how to check a hearing aid.
I mean, the first thing to do is to just change them anyway for a hearing aid. And if you're still not sure, I mean, there's various things that we do, like, loud clapping to the side and see if a patient will turn and respond to that sound. But also, yes, we can come up and we can support doing a listening check with that equipment to see if it's delivering sound.
There's a very basic way. Just put the battery compartment, just close it and just cup it in your hands, and if you get a nice whistle, then you know it's working. It doesn't tell you if there's any clarity, if the clarity's good, but as a basic, is it on or off, that would tell you. So if you've closed it and there's no whistle, the battery needs changing.
Yeah, and that's for hearing aids. Obviously cochlear implants are not going to whistle, because they work differently. So for any kind of hearing implant, then first thing, change the battery, check their chokes, so they're all rechargeable batteries and things. So yeah, for more complex hearing implant equipment, then it's probably best to contact us. Anything else? Oh yeah, there's one here. I work as a medical secretary. I find my phone the most difficult. Can I get a better phone? Do you wear hearing aids? I don't know. Yes, you do. Okay, so there are various phones and equipment, and it depends on the type of hearing aids you have, but things like Bluetooth streaming is a good option to make things a lot clearer. There are various amplifiers, streamers, there's lots of equipment available, and there is that access to work funding there as well. So yeah, I'm really happy for you to reach out to us, and we can have a one-to-one conversation if you like. But yes, there is equipment available, either special phones or equipment to help you link to the phone with a clearer signal. Anything to add, Gail?
Just if you look for Con Evans, it's a website that deal with lots of amplification equipment, and they have very good advice there too. So you can ring them up, or you can go online and look at all their devices, and they've got lots of supportive listening devices that you can look at, and they'd be able to give you some information too. But yeah, we're happy to help as well.
Yeah. Also, the Action on Hearing Loss. Oh, they're not Action on Hearing Loss anymore, are they? They've gone back.
They've gone back to the RNID. To
RNID, but that website, there's a section on equipment that can support, and it goes through the options that are available, because sometimes, you know, Con Evans is fantastic and they are great to support, but it can get a bit overwhelming on first look. You don't know what you're looking at and what's compatible. So yeah, the RNID website is a really good place to just look at what you can have for different situations. Oh yeah, and just to say thanks, Alex, that Workplace Adjustments team can support getting the equipment as well, and they've been really supportive with some of our patients recently. So yeah.
Nicole, I think Ian has his hand up.
Hi, Ian.
Hi. And I'm Ian. I'm the executive co-sponsor of the network with Ashley. Thank you both. Thank you, Nicola. Thank you, Gail. It's a fantastic presentation and really informative. I suppose just two things. One is, I don't know if this is more for non-T, I wondered if we have any sort of data on sort of the number of staff in CUH who do suffer from some form of hearing loss, and I recognise that's a difficult thing to sort of get as well. But and then for me, there's something in everything you said about awareness raising, isn't there? And it's an offer, I suppose, that with the communications team sitting in my area, if there's more you think we could do to work with you to raise both awareness of clinical teams for patients, but also of managers and colleagues for staff, then really keen to sort of be able to work with you on that, because clearly as we go into Deaf Awareness Week, it's really important that we get these messages out, isn't it?
Can I just say, I think the introduction of signing classes as part of the hospital sort of training programme has been really well received. You know, getting training and accessible training too, when everyone's working and working hard, is always quite a challenge. So I think that's been very well received, and something that would be fantastic if that could keep going in terms of that sort of input, because it's a bit like a lot of things, unless you do it all the time, you forget. So having that prompting and reminding is really useful. So thank you for sorting that out.
The other thing to mention, Gail, we've been working recently with a sensory impairment group within the hospital, and that's who is leading it?
I've forgotten surnames, but I know Molly and Claire. I've been linking with them, and we're looking at improving signing and signs within the hospital in terms of perhaps having some sign language access, and just Claire making things, and also videos, sort of signed videos that enable everybody to access all information. I think that's an area we could really improve on, because it would be, thank you very much for those names. I think that is definitely an area that, when we've spoken to the Cambridge Deaf Association in those chats, you know, it's not about everybody being highly proficient. It's about showing a willingness to engage, and just having access and some involvement of that level would be amazing. I just happened to be on a train earlier in the week coming back from a conference and saw signed interpretation of the trains coming in, and it's you know, you don't often see that. So as a hospital, if we could take that, something more like that on board, be amazing. And
something else that we looked at in that sensory impairment group was you know, the safety alarms that we have throughout the hospital, that, you know, we have a cohort of patients that will not hear safety alarms, fire alarms. So, you know, we need to have the visual adaptive alarms available as well. So they've been looking at things like that. It's just about starting the conversation and raising awareness. It really is. You know, you just have to start considering these issues.
Something that's not totally visible all the time. I think that's
exactly. Yeah. Yeah. There was one more. Trust offers basic BSL would be nice to have more in-depth learning for staff. I agree.
Yeah,
I agree, but you know.
Yeah, I think within in education, we're very keen to encourage, or have been very keen to encourage people up to sort of level 2 signing, because that enables you to have quite a decent conversation level with people. But it's not always accessible and easy. So I would agree with that. If
anyone is interested in learning BSL, the Cambridgeshire Deaf Association do evening and daytime courses, and they're really good, and they're run quite frequently. And there's online ones as well, isn't there?
There's a British Sign online course, again, if you want details, to contact me, which is free and offers you a nice coverage of range of topics that you can just do online in your own time, and with videos that are useful. So that's a useful place to start too.
Yeah.
Brilliant. Okay. Well, thank you very much, everybody, for dialing in, and thank you very much for Gail and Nicola for a fabulous presentation. We've too many questions. We've gone over time, but that's a great thing. I think that's a good sign to say you've got people really interested in the topic. I'm sure some people will take you up on those offers of getting in touch or doing the further signing online, and it's been a great source of knowledge. So thank you very much both for your time, and
thank you for asking us.
Yeah, thank you for the opportunity.
Yeah, great.
Really important, and I'm sure there'll be other things to look out for the week ahead. Okay, so lovely. Thank you very much, and really well done.
Everyone.
Really enjoyed it. Bye.
Thank you very much.
Thank you. Bye bye.
Thank you.
Bye bye. Thank you.
Bye.
Bye all.